I'm an epidemiologist, and when my daughter was in kindergarten, she went into school and she told her friends she was an epidemiologist. Her dad was an epidemiologist, and they kind of picked on her, and I told her that's what happens to epidemiologists. My wife told me that I had to explain to her how to best describe my job for a kindergartner, and I said, okay, well, I find sick people. My wife looked at me kind of confused and angry, which is a common look I get. But it's actually true to what we're talking about today. I'm going to be talking about strengthening the disease surveillance system with the Learning Health State. And these are existing systems, and I'm going to be focused on infectious disease and syndromic, because that's what I do. But there are tons of other systems in chronic and cancer that state public health works with that fit into this mode as well. So, public health surveillance is a continuous systematic collection, analysis, and interpretation of health data. Well, if you read that slide over, you see keywords like continuous, systematic, and the collection, analysis, and interpretation. It fits into a lot of things we've been talking about already today, right? So it's a systems approach, and disease surveillance fits that. The virtuous learning cycle, the analysis of public health interventions and how effective they are. The design of those interventions based on the population. I think it was Chuck's slide with the Vioxx, where you saw the trends in disease, public health intervention, the removal of the product, right, and the decline in disease. That's what surveillance is about. And we want to, speaking to that disease surveillance and syndromic, to improve the effectiveness of these systems by improving the timeliness and the accuracy of the data coming into the systems. The sooner we get information, I think that was Chuck's point as well, speaking about how real-time availability makes a difference. It makes a big difference in communicable diseases and syndromic systems. So, and kind of give you an idea of this, I'm going to fly through this. This gives you an idea of, just with one individual, and you can think of it in a population sense as well, the difference between the exposure to an illness, then there's an incubation time, the onset of symptoms, a time before seeking medical care, a time to diagnosis, reporting to a local health department, then reporting to the state health department. Well, our disease surveillance system kind of pushes that time window back for reportable conditions back to the level of diagnosis, especially if we can integrate with electronic health records where diagnoses are made, and then that message comes into our system automatically. We do it right now with electronic lab reporting. When a laboratory confirmed reportable condition is made in a number of laboratories, an electronic message comes into our system. But we also have a syndromic system that is pre-diagnostic. We can look at the chief complaints and other presenting information from patients in, right now, about 13,000 records a day from 92, I think, emergency departments. We're expanding that every day. We're broadening that to other groups as well. And then we have other systems we look at, like school-based reporting for aggregate illness, and we can push it even back to the point of exposure, just after exposure, where we look at things like the BioWatch system, which is a federal system monitoring air quality. Those results, those environmental samples, can trigger our enhanced look at our surveillance systems for different conditions based on what's showing up in those systems. They asked me to say what population this affects. Well, everybody in Michigan who seeks medical care, right? So if you're going to an emergency department of urgent care, you're going to your doc's office, you're getting a diagnosis or laboratory testing, these systems play a part in that. The MDSS, and I'll go through, I don't want to go through all the details of this because we don't have a lot of time, but the Michigan Disease Surveillance System is a web-based tool. It has the ability to receive electronic messaging and process it through kind of the state hub, and working with MyHand and substate HIUs to gather this information, electronic lab reporting, electronic case reporting, things of that nature. Kind of a big overview model talking about the outside world to the inside world of the state system on the right side where our surveillance systems are housed, but out on the outside where the integration with these other systems takes place. To gather the information that creates the referrals that go into public health, that are followed up on by public health and kind of inform our decisions. I'll say Chuck's name again, because Chuck was actually at the University of Pittsburgh working with the development of the real-time outbreak detection system, which was an open source project back in 2003, 2004, Michigan adopted as our syndromic surveillance system platform. And so we use it right now. It gathers a very limited data set consisting of, for every patient trafficking through these emergency departments. It gathers just some patient demographics and a chief complaint text. The new model with the meaningful use rules, the new model has a much richer database, data set that we'll be receiving in real time from our patients. So, and a quick model of how that works. This is closer, if you think of the MDSS, going back to I think Tom's slide about the Model T to the Google car. MDSS I would say is probably like a Chevy Cruze. All right, so not a lot of features to it, but it's better than a Model T. I think that the syndromic surveillance system is closer to a Google car because we're not requiring. This is kind of where we want to go with some other things. We're not requiring any intervention on the part of the facilities to make these syndromic reports. It would be too time consuming. So generating a message upon registration from these systems in hospitals and doctors' offices creates our syndromic messages, and that's what populates our system. So what happens with this stuff? I mean, public health interventions, these are the important things that happen when we are able to bring this information and interpret it. And these are things like recalls or medical advice, or we're talking about notifying the healthcare community about impending things and sharing information. All of this stuff that we were talking about earlier, all of these items are of public health importance, take place right now based on these systems. We can do them better. We can do them better in this kind of learning health state environment. We can do it better with more electronic messaging, with more consistent messaging, and that's what we're shooting for. And I think that's why I've been pretty active in participating in a number of these different activities. What do we need? We have existing systems. We're not building anything in a vacuum, but our existing systems are, a Chevy Cruze, right? So we have to continue. I think Tom mentioned we have to continue to advance with the technology to grow our systems, and we need support to do that. We need support to just maintain these systems in place in the state health department so that every local health department across the state has access to this information so that they can do public health interventions. But we also need to be able to be agile enough to adopt the technologies that are going to make these systems better. And we need resources to do that. We need to push more towards the Google car to integrate this reporting into the structure of the healthcare provider community. Right now, they do it fairly inconsistently, our disease reporting system. We know that as we get better and more electronic feeds automated from the systems, we're going to get more information, richer information, and more accurate information to work with in the public health sense. And we need to maintain the personnel and the staff that can respond to these things. Local health and state health departments need to have folks available to interpret and to develop the interventions that are necessary and to evaluate how those interventions are working based on the data we receive. What makes it easier for us? We have legal mandates for reporting in Michigan. We don't have syndromic reporting legal mandates, but we do have reportable conditions, and that while we honestly don't enforce communicable disease reporting rules, but we reference them really strongly, and I think that sometimes provides some impetus for reporting. Meaningful use, thank you, and all the people at ONC for including public health at the table, because we finally get to the Thanksgiving dinner, we go from the kids' table up to the adult table, and people are talking about public health surveillance and reporting, and the public health community was so excited about being involved that I think to a certain extent we might have exploded and gone too far. And now we're reining ourselves in and making it more productive and helping to define and how we can use meaningful use for public health reporting. And it's really exciting to be able to be at the table and to be recognizing the importance of what we do in public health. I think that's great for us, just spiritually, if not practically. We have existing systems with great capacity. Our systems enroll, all of our local health departments enrolls a bunch of state staff, provider networks that use these systems, and having effective systems in place helps market your systems. And so we have those in place, and it helps us do that. And then we always have the high-profile events that take place that help kind of lend some credence to what we do in epidemiology and infectious disease epidemiology, or just public health epidemiology, like the the Middle Eastern respiratory syndrome cases, the fungal meningitis outbreak associated with contaminated product. All of these things, I think, add some limelight to what we're doing and help kind of help support our activities. Obstacles. Now, I didn't name the slide obstacles. It was part of my template. I would call them challenges because I think obstacles are harder than challenges. We have to make sure we stay at the table, that we stay as a priority. And there's so many priorities in the healthcare community right now that we just have to remain visible, not by making outbreaks, but remain visible by identifying outbreaks and doing good work and staying at the table at events like this. The structure, Michigan's Health Information Exchange structure is different than some other jurisdictions. And it can be challenging because we have kind of a diverse group. And so it's certainly not insurmountable, but it does create a different challenge than, say, if it was a single state-run HIE. I think that might be more direct, maybe not as productive in the long run and not as inclusive. Data quality issues with our existing systems, we continue to work with in our electronic feeds. It's a struggle. We don't have a lot of enforcement authority. When we have enforcement authority, we don't leverage it, and I don't think we're going to. The disease reporting right now is it can be a manual process by providers, it can be telephone call, fax, whatever. So getting to a consistent platform of reporting. Some jurisdictions, some states have mandated electronic reporting into their disease surveillance systems, either through a web-based interface or whatever. I don't want to go that route. I don't want to mandate anything. I want to make it so it's more cost effective for them to work with us that way to meet their requirements. And we have some clinical labs that still don't have, they're not up to the capabilities to do electronic reporting. So we continue to help grow that system and increase our enrollment. So they asked me to target success, and I didn't give, like standard, too much of a standard commitment because I'm not sure exactly what success is I know what success for my systems are, but I don't know with the learning health state how that plays together exactly yet. What would success there be? So I started talking about electronic lab reports. That's something we're growing all the time. So increasing that percentage of electronic lab reports received by the state. Involvement, so system participation. I mean, that to me is a great indicator how many facilities are contributing data electronically to our surveillance systems. Looking at syndromic surveillance, we can target all of the state's emergency departments. So we're at 90 now, we can shoot for 200. At the same time, we're also working, and we built the system to gather ambulatory care data, and doing bad on time?
You're okay.
Okay.
Close.
Okay, close. But gather ambulatory care data beyond just emergent care facilities and look at that as well. We have those messages in place. We have the system built in place to receive that through the state's information technology infrastructure. And I was excited to hear about the progress that we're making with ADT transactions through MyHin, and mining those might be one of the ways we can get that information in a syndromic. So then we can look at, I think Tom might have mentioned that different things are based on different assessments are based on what the actual condition is. And we can look at condition-specific surveillance over a time period and look at improving critical surveillance issues, and look at utilizing things like syndromic surveillance for broader than infectious disease. Look at for healthcare utilization rates and things like that. So there's lots of things we can do. And the learning health system to me offers a couple opportunities. I think it offers a platform to help with the integration with all of these existing systems. I think as a concept, it's something that helps kind of weave together all of these health information exchanges, all of the networks, all of the learning things. And I think it can be, I'd like to think of it as a source of truth. So you build into your learning health system kind of these clinical support measures and things like that, clinical decision support, that can help provide kind of a consistent message to users about what is available out there. I think Tom was speaking to that too. What is out there? What decisions have been made? And where can I get the right call? So that's important to me. And also just kind of having that kind of one piece in place that we can work with is exciting.
I listened to comments in the audience and I thought, great, no one's going to sign up for immunizations because we've been around a long time and we're kind of stagnant. We have a lot of ideas, but we're not going anywhere. And that was the very reason for getting involved in this project, because vaccine preventable diseases need to be eliminated, and immunizations are the way, obviously, to do that. So this is the key in coming here today. Just a little bit of background for some of you who may not be as familiar with immunizations is that we have a program, a federal program called the Vaccine for Children program. It provides federally funded vaccines for children who are eligible under the age of 19. And what it did, it was put in place with the hopes to decrease the direct parent barrier to cost for vaccinations and to hopefully eliminate the disparities that we were seeing 20 years ago with all the children who are not being vaccinated. And indeed it has done that over the last 20 years. We no longer see disparities based on race, ethnicity, or income level in allowing our children to be vaccinated. So it's been that in part has been a very successful program. And indeed on the 20th anniversary, CDC published this statement showing estimates, if looking at that cohort of children born between 1994 and 2013, that vaccines would prevent more than 323 million illnesses, 21 million hospitalizations, and over 732,000 deaths amongst this cohort. So that's a significant value right there in human life, but it results in a savings of $295 billion in direct cost and $1.38 billion in total societal cost. So when you think about the Vaccine for Children program as a segment of that program, and we look at it as a cost of $4 billion annual tag right now, you can see the cost savings are there, and it makes this program seem a little less costly. But this is the importance of vaccinations, is it can do so much good, and it's being proven out. But we're also faced with a lot of current barriers other than the successes of the Vaccine for Children program is obviously in place, but we have current barriers that are there that continue or to stagnate our success or to allow us not to succeed further. This slide of the Health Styles Survey simply shows you in 2010 a quick snapshot of where parents were in their concerns about vaccination. That it is gladly and hopefully in what we feel is a success, that vaccinating children is considered a social norm amongst parents. That the majority of parents will go out, get their children vaccinated on a timely manner following the recommended schedule and receive all the vaccines that they should. However, a number of parents, and this number is increasing as days go on, intend to vaccinate their children, but are choosing delayed or alternate schedules as a mechanism to vaccinate their children. So they are getting vaccinated way past the time frame that we anticipate they should be fully immunized. Some parents are convinced that vaccines are going to harm their children, and they pick and choose which vaccines they will give their children, and those children will never be fully immunized. And we will always have a small percentage of parents who will refuse all vaccinations. So this has become our real national concern, and certainly a concern in the state of Michigan, the vaccine hesitancy that we are seeing increasing in our parents. And how do we resolve this issue? And beyond just the parents, we have vaccine hesitancy within our provider groups. We have providers who are picking and choosing certain vaccines to carry or make available, therefore not allowing the parent the access to those vaccines within the offices. So these all compound to be real concerns in vaccine hesitancy. When we look at Michigan data specifically, how does this interplay into our concerns here in Michigan, the hesitancy? And we see it simply in the national immunization rates that I've shown you here from 2012. If you look at this list, all of the individual vaccines needed for a child between the ages of 19 through 35 months to be fully up to date, the rates are at 81% or higher for each individual vaccine. But when you put them together, we can see the parents in Michigan are approaching the opportunity to pick certain vaccines, because we should have a rate of at least 81%, but indeed as parents pick and choose which vaccines to give their children, our overall completion rate for that age group is only 70%. So we definitely can define this program. We can see it in our data on a day-to-day basis, and we see these numbers growing. So these are just more magnified as concerns. Oops. What happened there? This is a case example. Let's take a look specifically at measles. Measles is a disease that obviously has been around a long time, and most of you in the audience will say that you had measles as a child, but you also ran the risk of encephalopathy and death caused by measles. It's never been a very simple childhood disease. It's been a harmful one. And so by 1996, the United States had dramatically decreased the number of cases of measles when using the vaccine. And what this led to was the United States being declared non-endemic for measles. And that was a big milestone for us. But in 1998, with the advent of a very small study by a physician in England, we ended up in a period where parents stopped receiving the MMR vaccine. And the reason was the study pointed out in short term that the MMR vaccine caused autism. And even though that linkage has been disproven over and over again, that there's no causal relationship between the MMR vaccine and measles and autism, the legacy of that falsehood stays with us today. And we still can go and antidote parents who say, I'm not taking the MMR vaccine for my child because I don't want my child to be autistic. So we work with this legacy all the time. And as a result of that, what we find is that we have a measles resurgence occurring around the world. Globally, many parents, following this falsehood about autism, determined that they were no longer going to vaccinate their children with the MMR vaccine. And now we see tens of thousands of cases in developed countries who had measles under control are now back in a measles resurgence. How does this affect us in the United States? We have a number of people from the United States, thousands and hundreds of thousands of people who travel globally annually. These people are bringing the measles disease back to the United States because they are leaving our country unprotected. And when they do that, they bring the disease back and they allow other susceptible or vulnerable people in our population to develop this disease. It's a cycle that's not stopping. We have increases in pertussis disease when vaccine use drops off. And recently we are hearing a lot of information about an increase in polio concerns globally going on because of decreased vaccination. So these diseases are out there, and while we can be happy about the successes and the dramatic decrease in disease that we have been seeing, we know that the disease is ready to show its ugly head if we choose not to vaccinate. The concerns in Michigan come down to two simple facts. We're concerned about the Michigan immunization rates in Michigan being below national goals, and that our childhood and school waiver rates are increasing. Right now, we've made great strides in immunizations in Michigan. In 1994, we were dead last. We were the 50th out of 50 states for immunization rates, and we successfully made it up to position 22. But that doesn't hold much ground when you have to talk to a parent who's lost their child due to a vaccine-preventable disease, when you have to write their story and share it with others to convince people that this is an important endeavor. Just looking at a few simple statistics here, I didn't want to bring all of them with me, but looking at that 19 and 30 to 35 month group again, which is really a key factor in looking at immunization rates, we look at our rates being at 70 up to 74%, depending on the study you look at, when the healthy 2,000 people goal is 80%. We have a vaccine called the human papillomavirus vaccine that could prevent cervical cancer in great numbers. It can decrease anal cancer and other cancers and other genital associated cancers. And yet, this vaccine has such slow uptake that we sit right now with a state rate of only 24% of our females being fully vaccinated and our males at 8.6%, when there's a healthy goal of 80% to try to achieve. It's a vaccine that shows it's getting a lot of hesitancy from both parents and providers. And unfortunately, these numbers just aren't moving anywhere. I thought I don't like to call them senior anymore because I'm getting closer to that 65-year mark, and I'll move over that hump pretty soon into the 60s. So I like to call them our mature population. But our more mature population, now even when I came into vaccinations 15 years ago, I thought every senior citizen went and got their flu shot annually. And indeed, the rates do not reflect that. The rates in Michigan show that in 2012, only 55% of that group actually received influenza vaccination. much dramatic difference. The 2010 goals were the same for the children and for the flu indicators here. We bypassed 2010 and just moved those goals up to 2020, and yet we're still a long way from meeting that. I would like to highlight the initiatives that are going on in Michigan, and I don't want to pay disrespect to the other initiatives that are going on. We have many good groups working on immunizations, from local health departments to private providers groups to health systems, all across the board. But the key is that we have many groups, and as you were talking about, they're all cycling out there separately. We've had the opportunity with the legislative support and guidance and leadership from State Senator Marlowe and his staff. Their leadership brought together a working group of multiple partners to include professionals, nurses, physician groups, to include health systems and hospitals, to include community advocate groups and community members, to relook at these concerns that we have in Michigan that are twofold: to decrease school waiver rates and to increase immunization rates. I apologize, I didn't fully talk about the waiver rates a moment ago, so I just want to share with you that as parents are decreasing or hesitant to take vaccines in Michigan, our waiver rate for school-required vaccines is decreasing. Remember, you have the option of signing a waiver in Michigan based on religious or philosophical exemption. And they are taking advantage of that till our rate is up to 5.9%. That put us in the last school year of 2012-13 at the fourth worst rate in the United States. Again, we're being indicated as a state who's on the bottom. So this was a key point in this group coming together, and setting a goal to decrease waiver rates was important because it's the first time we've had a state initiative that has legislative supporters to look at decreasing these waiver rates. And there's a couple indicators here that they're looking at. They're considering requiring patient education before a waiver can be signed, and the use of one state form. There are so many forms out there we can't keep track of the language. Increasing immunization rates is parallel on this board, and these two goals match the goals that were put into the working grid here for this summit. We have to look at both sides of the equation, looking at decreasing vaccine hesitancy on the part of the public, but also looking at provider education and giving them the tools to make sure that their recommendation is strong enough to support parents and their other patients to being vaccinated. This is our enabler. This is key to our success, or key to us going forward. Is the Vaccine for Children program is certainly important, but the MICR, the Michigan Care Improvement Registry, is our key database. When I first came into immunizations, I thought, okay, I'm on the education side. I have nothing to do with this tech side. I don't even want to know about this tech side. And I found over the years that everything we do in immunizations circles around the registry and the data. The data is there to provide support for all the endeavors that we do. This is at first a repository of vaccine doses administered. It's a very robust registry in that over 8 million persons in Michigan have a record in the registry, and you may have one and not even know it. The vaccine, key to the physician who was challenged with a very complex schedule and a number of doses that need to be given to children, the vaccine dose assessment and forecasting, that capability of the registry is key to them in promoting vaccines and making sure children are vaccinated. It provides real-time data. That's something we don't have the opportunity to have in all systems, but we can go down to dose data on a minute's notice and look at what's going on. And now we have an electronic data transfer that's being used by over 1,100 EMRs transferring data, interoperable data to the MICR, which is key. It goes away from that hand entering, key entering of the data and moving to a more streamlined system. Moving forward, we know that we have to look at two-way interoperability, and that's a challenge that we're focusing on now, making sure that there's talk between the EMR and MICR back and forth. We have to ensure that all providers utilize the MICR. It's a state law that children under the age of 20 have to have their doses entered into the registry, And pediatricians and family practitioners are very aware of this and do due diligence in that manner. But adults, it's not required. It's only highly recommended and allowed. And so we need to make sure that we look at vaccinations going forward across the lifespan, that we promote and ensure that all providers are utilizing this for all age spans. So in conclusion, how do we fit in? How does our board fit in with the rest of the boards here? And I made the comment when you added, the last group was added, that sounded like a really great group, and I kind of wanted to go over there. But I realized that we have to stay where we're foot. And the other thing is that I believe strongly in immunizations. I believe that we can succeed, but we need to look for a new or reinvent a new way to look at vaccinations in increasing levels. We can't keep going on. It's a tremendous amount of work, and I do not want to discredit the work that's going on immunizations. Just to get 70% of the children continually vaccinated is a huge undertaking, but we can't allow ourselves to remain stagnant. That allows over 30% of our children and a great number of our adults vulnerable to these diseases and the potential of dying from them. So the potential that I see is to utilizing the learning health state is to consolidate and synchronize the multiple state efforts that are going on. We need to promote and improve the linkage between EMRs and MICR, and I believe this cycle could benefit us in that way. And we need to increase the public engagement in eliminating vaccine preventable diseases. That's our goal. It has to remain our goal and our number one priority. Thank you.
Okay, for the next theme, I'd like to identify the problem that we are trying to solve. And that is that we now, at Blue Cross Blue Shield of Michigan, pay between $200 and $300 million a year for adult healthy physicals, well exams. So we were talking about resources earlier this morning. That's a lot of resources that are going into delivering this service. But we're not on a learning curve as to how to make this service effective. So how well are we doing? There was a meta-analysis published in late 2012 in the British Medical Journal that reviewed 14 randomized trials involving over 183,000 adults. Overall, general health checks had no effect on overall mortality, cardiovascular-related mortality, or cancer-related mortality. Likewise, general health checks had no effect on morbidity, for example, heart attacks, myocardial infarction, hospitalizations, work absences, disability, patient worry, or physician visits. In stating the obvious, the reviewer said, these results suggest that providers and health systems should redeploy resources that they expend on general health checks or healthy physicals to more effective healthcare related efforts. So the challenge for our group is to take what is already a very well resourced set of actions and make them more effective. So think about the health visit, the annual health visit, as a productive interaction. So you don't define that it's CPT 993XX, but it's a productive interaction between an informed, activated patient and a prepared, proactive practice team. And I think that you sort of open up the possibilities for redesigning. So the patient role is less passive, it's more active, and it's attempting to create in the patient a more effective, engaged steward of their own health and manager of their own conditions. And our role is to help or facilitate the patients doing a good job and being successful in this role. So what are we moving from? How long until things are normal and you can go back to ignoring your advice? 2, Mark Harmon, informed, activated health steward, I am my own secret weapon. And there's very, very little that we do today in this annual health exam that helps us move from the Lockhorns to Mark Harmon. So just a few thoughts to start it off, because I don't want to preempt what the group would decide, but let's think about it. There's a lot of historical information that's gathered in these annual physicals. A lot of it is a repeat from last year, and a lot of it is taking information in a very expensive way over and over again. Why are we not using our patient portals that we all implemented to input that information instead of taking so much time in this visit? Why not use that health portal in a way to create an ongoing set of productive interactions? And the state, I think wisely, now requires a health risk appraisal for Medicaid recipients. Why have we never included a health risk appraisal as part of our annual exam? Because what does a health risk appraisal do? It identifies the most important risks to your health in the future. It identifies the most important interventions that you can activate yourself to prevent or reduce the likelihood of those risks turning into actual harm or diseases, identifies the barriers that you face, identifies your readiness to do those behaviors, and looks at your confidence level that you can actually make a difference. None of that is currently included in the current service. So if we redesign this service in a learning environment way, can we achieve a mechanism? And we started off with one of your choices is to go to the theme directed by the Director of Communicable Diseases, and I would like to think of this as the other room where we're talking about the Director of Communicable Health, where we're actually using that encounter to stimulate people to do a better job in taking care of their own health.
So why the theme of coordination of care? And as I put together some thoughts, I was reminded that, certainly at the foundation, as we begin to move into a population-driven healthcare state, is that we have to understand that we're becoming reorganized around the triple aim, and we all understand those triple aim goals of using better coordination of care to improve patient outcomes and hopefully reduce or stabilize cost and enhance that patient experience. And I think we're beginning to have those discussions here today. And as we think about coordination of care, it's interesting. Our long-term focus has really been how do we coordinate or how do we care for patients when they're in the hospital? And as they leave the hospital, we forget about them. And so what we've learned, and just recently as we've been focusing on this, it's that critical time from when patients leave the hospital until they're picked up by that next care provider. That is a period of time that is fraught with opportunities for improvement, I guess is for want of a better word. So what we often see is, because we're not coordinating care during that time period, we have duplications of our tests and services. We find that medication errors occur, that there's often disruption in the lives of our patients because they're not getting the right information, or they're getting multiple sources of information, and this often leads them to come back to the emergency room or unnecessarily be readmitted back into the hospital. Just some interesting statistics are in our Medicare population. The average Medicare patient sees 16 providers per year. So think about 16 different physicians that are one single patient over the age of 65 is seeing as many as 10 in one single hospitalization. And as you think about that, then you can begin to understand why we're having problems around coordinating care, and specifically around the transition care. The National Transitions of Care Coalition indicates that 60% of reported adverse events, so as we think about the ability of our systems to do better surveillance about problems, problems, medication errors was the #1 reason following a hospitalization for an adverse event. So that there's a huge opportunity here to improve coordination and care. So if we think about our triple aim lines of thinking, I don't think that that we're achieving our goals of outcome, quality, and cost in the area of coordination of care. So to state our targeted theme goal for today is that frequent acute care readmissions due to gaps in care coordination services may result in these unnecessary costs and poor quality of life for our patients. So we've set our goal is to restructure and to focus on that transition of care process. Just some additional information in the state of Michigan, how we're doing. I got some information from our colleagues at MPRO. There's a couple of initiatives going on in the state. One of them is the Community Care Transition Program that is beginning to address the transition to care program. And the most recent data coming out of that group says that our readmission rate is still at 19%, 30-day readmission rate. It's also interesting that our state benchmark is 14.68, just to kind of put it into perspective for you. National readmission averages are that Medicare is reporting out is still in the 19% range, and they report that that accounts for $15 billion of Medicare spending. So just the readmission piece is certainly a significant cost to us all. How? I think that's why we're here today, is to begin to do that, and that this learning health system will begin to give us the opportunity and hopefully the tools to begin to address this, hopefully applying some of that basic scientific methodology that we've all been trained on. Some programs, though, in the state that I think have begun, although somewhat siloed, have begun to address this problem are I'm going to flip to this one, are some of the payment incentive programs. The patient-centered medical home program that Blue Cross and other payers have undertaken helps us to transform processes in which they were rewarded for improving outcomes, specifically reducing admissions and readmissions. Another big program is the Michigan Primary Care Transformation Program that I know we have folks here from that program today. And again, although we certainly haven't hit that critical mass, I think the data coming out of that has begun to say that doing that process improvement around admissions and readmissions through better care coordination will be something that hopefully a learning health system will allow us to expand and extrapolate those learnings. Some enablers, other enablers, Tim Pletcher's here today from MyHIN is, and he shared this information that I can share with you today, is we think that obviously data is going to be one of the core enablers as we begin to improve our readmission rate. And today, hospitals now, through Blue Cross mandates and other incentives, are sharing 70% of their ADT information. And then on the receiving end, we have over 20 physician organizations who are now taking that information in and hopefully using that to better understand the transition and care process and being able to reduce readmissions. In addition, I think that identifying active care relationship services, which may be a new concept for some of us here today, but this is, I think, at the core of understanding transitions of care and care coordination. And so understanding who is accountable and responsible and collecting that information and then sharing it across all care providers is going to be important. I put up there collecting the correct information. I would like to challenge us as we think today about care coordination and transitions of care, that certainly understanding where patients are along the continuum is important, but also specifics about the events that occur and why are we gathering the right information. So I would say the answer is no. We understand who the providers are and we may understand where they are, but as an example, one of the pilots that we're working on right now, it's a CMS funded pilot specifically focused on reducing readmissions readmissions is we're going out into the homes. This is a patient-centered medical home extension, and what we're learning through learnings from our home care folks is that there's information that we collect in the OASIS database that we think would be valuable. So I would challenge us that in our learning health state that we also need to understand that although data is important, we need to also be flexible in understanding that we need to collect the right pieces of data. Additional relationships. So I wanted to include this. I thought that this was probably more of a soft data point than anything else, but I think at the core of understanding transitions of care and care coordination is not only the patient-provider relationship, but the relationship of patients and their families and their caregivers. So going back to the example of our CMS program, what we've learned is one of the number one predictors for patients being readmitted back into the hospital is not whether or not they have their medications or whether or not they're going to see their primary care physician, but it's us being able to assess and measure and enable the caregiver support for those people. And I'm talking about our frail and elderly who are often homebound. So what we're finding is that if they don't have good caregiver support in understanding, then the patients end up back in the hospital. So I don't think we're adequately collecting this type of information today. So again, I've put communication, if you go to the last bullet up, is one of our barriers. The other, just to kind of finish out the point of communication, in addition to understanding caregiver support and capability, is health literacy. We have lots of information and data that we're collecting, but we're not able to translate it or communicate it effectively to our patients and their families. Health literacy has certainly been called out as one of our major barriers in being able to better coordinate care and leads to readmissions. Last on the communication point is going back to thinking about we have 16 providers taking care of a single Medicare patient. How well are we coordinating that information and even gathering that basic data and information and sharing that among providers? So hopefully we'll be able to take a look at that today. As far as the data that we are collecting, I think we're collecting a lot of data. I wish now that I had included a slide that shows the curve that as we gather more data, we decrease our confusion and we improve our intelligence, but then we hit that critical turning point now where now we have too much data and too much information and now we're all confused. Hopefully we can begin to kind of skinny down the amount of data and information and pick what those right data points are. One of the points that's already been brought up today is that we encourage individuality as the way that we're paid as healthcare providers and the way that we're organized and the way that we compete against one another for the market. And so certainly our data supports the way that we're paid. So we have multiple EMRs, we have interoperability issues, we have lack of standardization of the data that we are collecting, and certainly the way that the HIEs are set up in the state. Although it's improving, I think that certainly is a barrier in causing us to have increased readmission rates. And then finally, the payment disincentives. We've got new incentives, but again, I don't think we've hit that critical mass. We have too many care coordinators. We have too many providers competing for that care coordination activity for our patients. And as it is today, as we begin to start moving towards pay for value, I would challenge us that we haven't hit that tipping point and we are still paying for volume. So until we get aligned around what the value is and begin to pay for that, we will continue to struggle with coordination of care and readmissions. Another question, and again, I think this comes to along the same theme, is understanding responsibility. If you look at the grid that we're going to be working with today, it identifies, at least around coordination of care, that we all are key stakeholders in this question. So not only the healthcare providers, but the payers, and certainly understanding the consumer and caregiver and family accountability. Tom certainly talked about that in change changing the focus of the annual physical to begin to really move some of that accountability to the patient and helping them so that we become enablers rather than just directors of their care. But I think that this is a question that we have to begin to discuss as well. And finally, just some final thoughts on how a learning health system can certainly contribute to this initiative. I think it's interesting we came up with this statement, and it was certainly in Chuck's presentation this morning. Every patient's experience will be available to understand the continuum of care. Certainly without this, we can't begin to better coordinate care and specifically reduce unnecessary readmissions. I think we need to use the people and the intelligence in the room today to come to an agreement and begin to define and test ideal models of care delivery. We have certainly examples of that in place today, but maybe to pick a few and begin to focus on that. We talked about communication. There's certainly data underlies all of this, but I think we need better data and the right data, and then be able to communicate that across all key stakeholders, and a learning health system can help us with that as well. Then using that, of course, and using our PDCA cycle is to understand what the success measures are, to measure those, and then to obviously do what Chuck called, the right side of the curve and being able to act and change. And then finally, and I don't know if this is the elephant in the room or not, but I think we have to talk about payment and payer accountability. That certainly, I can tell you as a physician, I'm paid, I do what I'm paid to do, and so that if you want me to improve coordination of care and to reduce readmissions and to be a better enabler for my patients, then we need to really seriously look at payment accountability. I think this provides us a huge opportunities. We've got the right players in the room. Let's be one step ahead, and as we design these systems, let's put the right payment systems in place as well.
How can we really strengthen and align or realign payer incentive quality programs to really accelerate the improvement that we need to see in the patient experience, the value, which is really the quality and the cost equation of the triple aim and community health? And I think that as I was thinking about that, and as I started making a list of all of the current initiatives that are going on to try to drive quality, the list is fairly voluminous. And the question really is, are we approaching this in a way that really gives us the best chance to succeed and really achieve the goal that we want? So I made a list of some of the current initiatives that are going on in the state and across the country. The list here, I went to U of M's page because I knew they were the most esteemed and august institution in the state, which has always been a challenge for me because I graduated from Michigan State Medical School, and I've always had this inferiority complex when it comes to the University of Michigan, as they refer to themselves. But these are the initiatives led by the University of Michigan Health System, which I also thought was interesting, and you can't really see the names there, but I think the point is just the sheer number of different initiatives that are going on in the state that healthcare providers, health systems are engaged in. And I think a lot of times it's easy to lose sight of the impact that has on an individual provider who is trying to provide patient care. When you look at the variation in these programs between payers, I have a list here which we will again be going over at my table. This is the Spectrum Health list of quality initiatives. As you can see, it's a 3-page Excel spreadsheet, and you probably can't see the checks, but each column is a different plan, sometimes within the same health system, with different payer incentive programs. So one payer that we work with identifies good diabetes care as achieving a hemoglobin A1C of less than 9%. Another says that well, it's great if you can get it below 9, it's even better if you can get it below 8%, and it's best if you can get it below 7%. And they have different thresholds for each of those. And then one payer pays us to do that in their commercial plan, and another payer doesn't pay us in the commercial plan, but does pay us to do it in their Medicare plan, their Medicare Advantage plan. So there's a ton of variation, and I would just say that given the fact that the United States loves diversity and variation, if you're a typical American, you should really come to my session because you will be inundated with diversity and variation, and it's really where everybody in this room should want to be. Although I will say that the emphasis will be to try to reduce that. So, but the point is that I think we have to somehow decide what it is that really will work best at getting us to where we need to be. And so to me, the value of a learning health system is to answer that question. What should we be aligning these programs with? Should we be aligning these programs with each other? Should we be aligning these programs with the ultimate goal of providing better community health in the population? What percentage of patients are a priority health member for 10 years of their life and then become a Blue Cross Blue Shield member, who eventually then become a Medicare member? And should we be asking the payers to develop a program that recognizes the fact that there's a tremendous amount of movement from one health plan to another, and they have to be good stewards of patient health as effectively as they're good stewards of their company's financial resources? And should we then ask the same things of ourselves, health systems? Because right now there's an incentive, or there's a tremendous value to health systems being able to say that they're better than one another, as there is for health plans. But is that really serving the ultimate needs that we have in society for Spectrum Health to say that we're better than Mercy, or that we're better than Trinity, or that we're better than the University of Michigan? When in reality, if we really looked at how much leakage there was across those health systems, we realize that if we don't do a good job at Spectrum Health, then that eventually is going to result to a patient who's more ill going into another health system, and it's going to have this trickle-down effect on everybody. And I see that the real value in the learning health system may be, and these were just my ideas, so I'm going to be interested in your feedback at the session, but how do we really reduce the cost of care? What incentivizes us to work better? Many payers, including governmental payers, have chosen to use the curve. But if we were all students in a classroom and we were all performing on a test between 90 and 95%, those were going to be the scores of everybody in the room, from 90 to 95%. How many of you would feel like you were treated fairly if only the top 25% of you were given a passing grade? So is grading quality on a curve really an effective way to keep health systems and payers and physicians engaged, knowing that if they hit 98% or 99%, they could lose the reward because there were 25% of the health systems or physicians that they were being compared to that actually did better than 99%. So those are questions that I have all the time, and I get physicians pushing back as we talk about payer incentives, because they ultimately feel that they're not sure that this is the best way to keep them engaged and incentivized. So I think it'll be interesting to get feedback from those of you who do value diversity and variation who come to my session. So I think the other values for the learning health system I put up there in the interest of time. You can read that as well as I can. But I think these were just ideas I threw against the wall. I really think that as we mentioned earlier, the value is going to be getting more feedback and getting more ideas of what you all think the value of the learning health system can be as it relates to developing a very, very robust system that allows us to incentivize the behavior of health systems, providers, practitioners of care, and the payers to come up with a way that when we look back from 2020, we're just amazed at how much improvement we've seen in the last 6 years. So, measures of success. Again, I think one of the measures of success is to just see how much of a reduction in variation we could see amongst various incentive programs, to see whether or not we've actually moved the needle with the type of incentive program that we have, or are moving the needle, or whether we need to change the incentive structure. And then the baseline values that we have right now, and as I thought about it, and as I listened to your comments, Chuck, I was thinking about this because I came into this thinking that the baseline values were how well we're doing on quality measures right now, but I think maybe the better baseline is how well is the system working at helping us identify how to improve rather than where we are. Because the value to me, as I've listened to this, of the learning health system is, let's measure how we're doing at actually creating change rather than where are we in the system right now with our actual measurement, or what are our test scores. So I've kind of, as I was sitting here this morning, I've evolved a little bit, I guess, in my thinking.
I was asked to talk a bit about and to help facilitate this afternoon's discussion on the theme of designing an innovative model for shared decision making for patients. And so I wanted to take a moment just to kind of give a general understanding of what we thought that was, and I'm very hopeful that some of you will join us in kind of exploring the topic and coming up with some new ideas related to that. We found this quote that I think kind of spoke to the idea of the shared decision-making process, which is defined as a process of interacting with patients who wish to be involved in arriving at an informed, value-based choice among two or more medically reasonable alternatives, which have outcomes that patients value differently and where there's no clearly indicated best option. And as I read that, there's so many different things that swirled, and I think they all coalesce nicely with a lot of various initiatives that are in place that kind of speak to this patient-centered or person-centered approach, patient-centered medical homes, care coordination, all the above, in which the speakers have spoken about before me. And so, in a lot of ways, this idea of the patient-shared decision-making process is kind of the last manifestation of that. It's not just patient engagement, it's how patients are actually going to be part of the process in which they feel empowered to kind of see their care taken to the next step. So which population levels does this affect? This of course affects all the areas, including the individual, provider, public, and society, but really in particular, of course, this really stressed on the individual. Actually, to take it one step back, just to give you an example of what we're talking about with the shared decision making, research tells us that, for one example related to breast cancer, that mortality rates for women with earlier stage breast cancer are roughly the same whether they choose the lumpectomy route, which is removing just the cancerous cells, or a mastectomy, of course removing the entire breast. But of course, the procedures thereafter differ quite a bit after that surgery. Lumpectomy is usually followed by radiation therapy and comes with a higher risk that the cancer will indeed return. And of course, mastectomy is of course very disfiguring. So if I was a patient faced with that very difficult decision, it becomes a very personal one in which I have to evaluate what is the right choice for me. And so this thing really gets at the idea of what tools are out there to help a person faced with that very difficult decision, to help assist them in making that decision. How do they find themselves in the myriad of different statistics, journals, etc., to see where they fit in and how to arrive at something that feels right for them, and that of course ultimately is successful for them too. Along with that, I wanted to bring up a recent news article that came across my desk, and it was really interesting to me because it talked about the patients providing patient health information. So Apple has created a new tool called the Health Kit, or Apple Health Kit, which is exciting, but there's always all kinds of new patient tools out there that are popping up day to day. What's really interesting about this one, as I was reading the article, is that it's being endorsed by the Mayo Clinic, which is great. I mean, here you have a huge health system that's very interested in this particular patient app. And on top of that, this Apple is starting to have discussions with Epic, one of the nation's largest EMR vendors too. And what this article was talking about is that the potential of a person to really starting to be empowered to take a look at all these different sources of data that they're being pulled together with this patient app, and then potentially this being integrated, or their EMR data being integrated into this app. So kind of that bidirectional exchange of data from a source, which could be the provider and their EMR, to them at the patient, or vice versa. This, of course, calls for a tremendous amount of interoperability. I think this is something that there's so many different things that have to be assessed along the way, including things like the FDA regulations that are trying to assess of what a patient app is, if it's really in the clinical sphere, or if it doesn't need to be regulated. So many different things to consider. This is why I've grown incredibly, very much interested and passionate about this particular theme. I think there's a lot to learn, and hits on all kinds of different goals and concepts that are swirling around, which in fact brings me to the next slide. I wanted to talk a bit about some of the supporting initiatives that are going on here within the state. As noted, I think they hit on a lot of those key themes, whether we're talking about our integrated care demonstration for the dually eligible, a recently passed Health in Michigan legislation, which of course has seen tremendous success in seeing new enrollees into the program, our MyPick program, which is talked about quite a bit about here today, along with, I was really excited to hear the question about the Blueprint for Health Innovation, which is of course our SIM model, which we'll be submitting our test proposal here soon. Within all of these, the concepts of care coordination, patient engagement, and person-centered approach are paramount. And I think the whole idea of creating a model in which the patient shared decision making really kind of builds upon those ideas as well too. So I definitely think this theme has a place. So what this might require, I'm borrowing language directly from the learning health system world and saying it's going to require resources or access to resources such as portals and decision-making tools, which could be something as simple as a Fitbit, or for another example, that new app from Apple that I talked about. It's to require activation or motivation on the part of those to participate in that shared decision-making model and engaging in healthcare, both from the provider sense and the patient sense. Health literacy, the ability to understand the health information which is being presented in front of you. And of course the opportunity or the chance for those individuals to participate in the decision making and feeling empowered to make meaningful and choices that are right for them. So what are some of the current technology enablers that we have going on? Of course, meaningful use is a big one. It's kind of the giant carrot that's kind of got a lot of things in motion. We've seen the growth in the way of patient portals, which I think is a great start in allowing patients entry into the process. Within those portals, many providers are offering patient-specific education resources within there, or also more leads into the clinical decision support to improve the performance on high-priority health conditions. But I think we're just at kind of the start of all of this, and there's more to come. Another enabler, of course, is our current work within health information exchange. I see this as a huge one. We've made a tremendous amount of investments here within the state and getting things started with that, and I see that being a huge enabler in the future too. That, of course, includes our different exchanges themselves, as well as MyHIN as our state-designated entity and our major network, really, and convener of all of those groups. Some of those some obstacles I do see, and as Jim likes to put it, challenges. Consumers can be really overwhelmed with the amount of information that's at their disposal. It's not easy to navigate. I'm not a clinician, and I have a tremendous amount of difficulty in figuring out what my labs actually mean if I get a copy of them, which also kind of speaks to my low level of health literacy within that. And the current healthcare business flows that don't really may not currently fully support personal choice. Although, like, as I noted, I think we're really working towards something to improve that. On the provider side, not all provider types are currently incentivized to establish those consumer-facing tools. What's really why should they become involved with that? That's a huge challenge. Another challenge is with that upsurge of all those portals creates a tremendous amount of confusion and just almost portal overload for both individuals and providers. So how do I see us working forward? And these, of course, are just suggestions. I think that we have so much more to talk about within this theme, and we can add on, edit, change, etc. But I think as a result of what we know to be true about the LHS system, we're looking for it to transform the data into actionable knowledge. So really, data is the key. Data sharing is a big piece of making an LHS a realized thing. And so we need the resources to create that opportunity for patients to participate in that decision-making process. We need to disseminate the knowledge back to the decision makers themselves and increase health literacy across the board. And also, of course, maintain public trust. It's that activation or motivation or consumer engagement piece is really such an important piece of all of this. These are purely examples, too, when we're talking about measuring the success. For example, we could be talking about targets of increasing the number of shared decision-making programs that are out there. We could be talking about just increasing in individual and provider satisfaction as how it's measured through potential surveys, or baseline service values, which of course be dependent on what we're talking about. I give the example of spine surgery here, but I'd really take it back to my first example of a patient with early stage breast cancer faced with A or B and not really quite sure what makes sense to her. So something to think about.